Good morning, everyone. And today our topic of discussion is disturbance of consciousness or altered level of consciousness. And before starting this topic or going in more detail, uh, many people they mix few things. They confuse loss of consciousness with or altered level of consciousness with syncope, vertigo, dizziness, blackouts. Okay, like things like this. So we are going to talk about them as well. So, what is consciousness? Consciousness is simply the state of awareness when someone is aware and he knows what's going on around them and they are oriented in the time, place, and space. Or you can see the definition the state of awareness of self and environment and responsiveness to external stimulation and inner need. So, and what is unconsciousness? Like, again, the opposite of this thing or a state of unawareness. Uh, like and the person he is not aware of what's going on around him. So the consciousness level or wakefulness or alertness, basically we check by a very famous thing, called as GCS, like Glasgow Coma Scale. And here is like um, few of the very basic things, like if you know what is reticular activating system. And of course, like uh, when you will study neurology or neuroanatomy, you would know that the cortex is the one, or the cerebral cortex are the one where all the higher functions or the centers of all the higher functions which we are performing, like whatever it is, you can say you think, you talk, your language, your comprehension, your moves, your sensations, your intellect, your memories, everything is the function of the higher cortical region. So, whenever we sleep, by the way, what happens, like the reticular activating system, you can say it's a switch which basically cut off the cortex with the rest of the body. Okay. Uh, like I'm using really simple terms, by the way, it's not that much simple. Like it's not simple at all, you can say. So, uh, the point to take here is like it's a reticular activating system which basically shut off or connect the higher function or the higher centers of the brain with the rest of the body. So that plays a very important part in maintaining the consciousness level. And you can see like widespread damage in both hemisphere. There is global suppression of the cerebral function. And like if you'll say like the brain stem lesions that cause proximal damage to the reticular uh, like when the reticular activating system is damaged, so like there is severe type of what you can say consciousness disturbance, right? So that's why this reticular activating system is playing a very important part. So and now there are a few terms, like then I will discuss some other terms as well, which I told you, like dizziness and all those things. And in this lecture, like I combine two topics together because they are closely related with each other, or you can say not closely related with each other, rather like they are, many people they misjudge or mix both of them. So confusion, what is confusion? Like confusion is lacks precision, but in general it denotes an inability to think with customary speed, clarity, and coherence, and results often from a process that influences the brain globally, such as toxic or metabolic disturbance or dementia. For example, we call something called as encephalopathy. So what's going on in encephalopathy, like hepatic encephalopathy or uremic encephalopathy, or when someone is under certain drugs, like simply, uh, uh, the person mind doesn't become like stay clear. Rather, um, what happens is they cannot um, think properly. They cannot respond properly. They do respond, they do think, but like not properly. So, like not with precision. So, what is thinking? It's a term that refers to problem solving or coherence of ideas. Now, the thing is, we have to remove this to make it clear. Okay. Now, see, like again, more terms. These are, you can say, uh, the stages or the levels of consciousness. Drowsiness. Now, what is drowsiness like? When someone is drowsy, so like it's hard for them to stay awake. Okay. And then there is stupor. Stupor can be described as a state in which the patient can be aroused by repeated stimulus. But now the state of arousal cannot be sustained without that repeated stimulation. So once you are going to remove this repeated stimulation, the person is going to go back into that state. Okay. Uh, like we know now that we sleep as well, right? So when we sleep and someone is going to provide any external stimulus, so what happens? Like you wake up, okay, and when you wake up, by the way, like it takes some time, to be in your senses, back in your senses. But that time when you are not back in your senses, you can say basically you are drowsy that time, right? So now uh, now we know what is coma. Coma is like when the person cannot be aroused by giving any external stimulus. Okay. So if a person is in coma, of course, like if you like whatever you will do with that person, they are not going to respond to you. So it means like the patient is in coma, right? So and then there is semi-coma as well, if you can see over here, right? So coma is, you can say, a deep, like the deepest state of coma, or like which is unconsciousness or complete unconsciousness. We cannot awake the person whatever you will do. External stimulus means what? Like you can give a painful stimulus, you can give a, see, you are sleeping and suddenly there was a bang, or there is a loud thunderstorm. So that's a type of, you can say, light as well as sound stimulus, like you will wake up from that. But of course, like the person who is deep in the coma or in deep coma, of course, like they cannot be like you cannot, no stimulus is going to raise them. So uh, what happens now? What is the difference between coma and death? Uh, when we say that the person is in coma, it means like his brain is still functioning. And how we see the functioning of the brain is by checking different reflexes, like pupillary reflexes. Like when we throw light in their eyes, their pupils, they constrict. Or corneal reflexes, like different reflexes can be checked. Uh, so now what, when someone brain is not working and we give them these stimulus or like these reflexes and they're not responding at all, it means like the person is brain dead, right? So this is the difference between, what you can say, coma and other things. Okay. Now a few more terms, by the way. There is something called as the vegetative state. So the syndrome of unconsciousness awakening has been referred to as vegetative state. And if lasts 3 months after non-traumatic and 12 months after traumatic injury, the syndrome has termed as the persistent vegetative state. So you can see like it is unconscious awakening. Okay, so the person is unconscious but awake, so we call it as vegetative state. And then there is a stage called as minimally conscious state. Okay, now there is something called as locked in syndrome. And to understand locked in syndrome is basically uh, you must understand how the central nervous system works. Like these are the people, by the way. Uh, what happens is like they have a stroke, and the stroke, like which occurs due to basilar artery occlusion, basically cut off all the motor as well as sensory tracts from the rest of the body, and what is still working in them is their higher centers. So they cannot even move their eyes. So these are the people who cannot move their hands, who cannot move their legs, who cannot move their eyes, or who cannot even talk, but still their higher functions of the brain are still working. They can think, they have memories, they have everything, but they cannot move at all. We call this thing as locked in syndrome. So it seems like the person is locked in. He have the consciousness, okay, but he cannot move at all. It is called as locked in syndrome. So you can see the infarction spares both the somatosensory pathway and the sending neural pathway, responsible for arousal and wakefulness, as well as certain midbrain elements that allow the eyelids to be raised and give the appearance of wakefulness. The lesion essentially erupts the corticobulbar and corticospinal pathway. So the corticobulbar is like the fibers which are coming from the cerebral cortex and ending up in the brainstem, and corticospinal, which are the fibers starting from the cortex and going all the way through the spinal cord and controlling the motor system. They are the one which are cut off. So that's why the persons cannot move. And now, what is brain dead? Brain dead people are those people, guys, like simply when someone is completely unresponsive, as well as uh, there is no changes of the EEG, which is electroencephalogram, and there is arrest of respiration, and whatever you are doing, they are not showing any responsiveness, right? So, okay, a lot of things are written over here, uh, like 25 milliliter per minute per 100-gram brain tissue, like the blood. This is like the blood supply to the brain. Okay, so whenever like the blood supply to the brain is less, so what happens, like the EEG basically slow downs. Okay, and what happens is like syncope or impaired consciousness. Okay, but when the blood flow decreases more, half of that, you know, then there is electrocerebral silence, coma, and cessation of most neuronal, metabolic, and synaptic functions. And when there is shut off of the metabolic or synaptic function in the brain, of course, the story is end, by the way. Okay, the brain will not function anymore. So this thing, I explained you already what is Glasgow coma scale and how to do that. Maximum the person can get is 15, and the least the person can get is 3. And one of the thing, by the way, to remember, like from this one, anyone whose GCS is less than 8, it means like the person is in coma. Okay, so uh, now whenever the person is in coma, there are certain causes. Okay, one of the way to remember like the causes of coma can be done by like mnemonics. Okay, I will give you some mnemonics, by the way. But see, what are the etiologies? Infections. There are non-infectious diseases of the brain, like cerebrovascular disease, stroke, brain tumors, brain injury, epilepsy. Endocrine and metabolic disorders like uremia, hepatic encephalopathy, pulmonary encephalopathy, diabetic coma. Cardiovascular diseases like arrhythmias, shock, and Adam-Stokes syndrome refers to a sudden transient episode of syncope, occasionally featuring seizures. Okay, and water electrolyte imbalance, exogenous poisoning like alcoholic intoxication. or like this is basically alcohol intoxication. Physical and anoxic damages, like anoxic, like there is no oxygen, so heat stroke or electric stroke. So of course, like this is the pathophysiology. Anyhow, we are going to talk about you can say the possible causes of coma, like whenever the patient comes and you found them in coma. So the things can be remembered in this way: A, E, I, O, U. Okay, so these are all the vowels and tips. Okay, so A, E, I, O, U tips. So now see, these are the possible causes when you are dealing with the patient. So like acidosis can lead to coma, as well as alcohol can lead to coma. E is for epilepsy, can lead to coma. I is for infections, meningitis, encephalitis can lead to coma. And O is for oxygen. So remember, hypoxia can lead to coma, as well as opiates can lead to coma. U is for uremia, can lead to coma. T is for temperature, like hyperthermia or hypothermia can lead to coma, as well as trauma, especially remember about head trauma. I is for insulin. So whatever, see, like if insulin is too high, okay, it will cause hypoglycemic coma. If the insulin is too low, it can lead to diabetic ketoacidosis or hyperglycemic state. Okay, oh, they can both lead to coma. P is for poisoning. Many poisonings can lead to coma. And S is for stroke, can lead to coma. Okay, so like these are all the possible causes of coma, which you can remember. Okay, and whenever like we know that the person have coma, and it is like due to some toxic or uh, like we are suspecting a toxic or a metabolic cause, then remember it can be remembered by metabolic. Okay, so M is for any major organ failure, of course, like liver failure, kidney failure, okay, heart failure. E for electrolytes imbalance, and there are many endocrinal causes of coma as well, like hypothyroidism, hyperthyroidism, okay, hypoglycemia, hyperglycemia, toxins or temperature. So like both of them, that like the good mnemonics you can remember. So acid disorders, or you can say acidosis, okay. Base for base disorders, okay. Metabolic, sorry. So B is for base disorders, can lead to coma. And O is for oxygen, so oxygen level are less or hypoxia. L is for lactate, remember lactic acidosis. I is for insulin or infection, okay. So whatever you like, you can remember. C is for cardiac or even hypercalcemia, but like that's not important. So like see, all of these can lead to coma. So or you can say altered level of consciousness, right? What are the clinical manifestations is of course, like these are all the stages of, you can say, or the degrees of unconsciousness. Like the most severe one is coma, stupor, confusion, somnolence, and inattention. Rather, I must bring it close, like here. Okay, so of course, like this one represent the minor forms, and these one represent the severe form. So like this one is the severe form, this one is like inattention. Like you can show this inattention like usually many of the times, right? So again, like the same thing, what is somnolence, right? And what is confusion, what is stupor, and we have discussed this thing, what is coma, okay. So see here, there's mild coma, like there is no spontaneous activity, no response to sound, optic stimulation, only able to mount defensive responses like painful expression or withdrawal of the limbs. So this thing, and then there is moderate coma, and then there is deep coma. Like of course, when there is no deep reflexes and no reflexes at all, it is like deep coma. So now, what is delirium? Uh, Delirium is when someone have uh, like the patients can go in delirium when they are under alcohol. Okay, for example, like when someone have taken drugs, they can be delirious. Okay, delirium can be caused by hypoxia. Delirium can be caused by infections, and the most easiest definition of delirium is like it's an acute confusional state. Okay, and simply the functioning of the brain has declined. Okay, but for a short period of time, of course. So the patient's awareness is fuzzy, ability to orient itself is lost, feelings are confused, movements are restless, and spoken words are disorderly. Like this is just to tell you, if you want to see a delirious person, think about a person who have just now consumed full bottle of vodka. Like how he will behave. Of course, his behavior will be like delirious behavior. Okay, so and then we can look for any accompanying symptoms. For example, if someone have bradypnea, like decreased rate of respiration. So think about opioid poisoning or morphine. With fever, if someone is presenting, so it could be meningitis, encephalitis. With mydriasis, think about alcohol poisoning. With meiosis, think about organophosphorus, like pesticides poisoning. Okay, or morphine poisoning. Bradycardia, intracranial hypertension. So like these are, of course, if you know what are the causes, so you can say you would know like what is the thing. So one thing is what you can say. People say like dizziness or blackouts or funny turns. So what are these? Again, these are also altered consciousness level. Okay, but uh, again, when you practice medicine, you have to know the meaning of these things in your own language. But many people, for example, they come and they say that they have vertigo, but like what actually they mean like is basically they have a funny turn, or like they went blackout, or they had a syncope. Okay, so what is this? Like the black down or funny turn is most of the time is used for to describe like altered level of consciousness. Many people they use these terms when they had what you can say a short period of amnesia, like their memory goes away. Okay, uh, whereas this dizziness word is usually described uh, to describe like when they have clouding of consciousness. Okay, or you can say when they have some abnormal perception of the environment. Okay, so like when someone typically have vertigo, what they say that the things are moving around us, revolving around us. So like that is a typical presentation of how the patient described like he have a vertigo, right? So of course, like we must take a very careful history in these patients. Okay, just to make clear like either what person is describing is basically an episode of loss of consciousness, or altered level of consciousness, or vertigo, or XYZ, right? So, of course, like when we will study vertigo, you would understand what I'm talking about, like what is vertigo. Then there is something called a syncope as well. So, what is syncope? Syncope is simply when someone has lightheadedness, and it could be, for example, if a soldier is standing in a parade or in some duty, and it's hot weather, so sometimes they can fall off to the ground, and as soon as they fall off, the the blood to the brain again started going, so they regain their consciousness. So you can say like syncope occurs due to global hypoperfusion of the brain. Okay, and then there is a term called a seizure as well. So seizure is, like when someone have what you can say, uh, some like abnormal movements of the body, you can say, or sometimes it is like just loss of consciousness without any abnormal movements. But when the person wake up again or come back to the normal senses, they are confused and they are drowsy and they go to sleep. So vertigo is best defined as abnormal sensation of the surroundings, okay, or abnormal perception of the surroundings or movement, like someone things are moving around you. So anyone who have like altered level of consciousness or altered uh, state of consciousness, of course, like we obtain a history. If the person can give, so from the person. If the person cannot give, so a collateral history from the family, from the friends, from the police, from the paramedics, from anyone who is bringing them. Or sometimes in developed world, they put the bracelets on the people who have some certain serious conditions, so they are wearing some bracelets. These are called as medical alert bracelets. So whatever, like we always ask like about the odipara, remember, onset, and how it progresses, right? So we ask like any fever, any trauma, any seizure, any abnormal movement of the body, any bleeding, any cardiac issues they have, okay, any toxic or metabolic state or cause, infection, all these things, right? If the person have the similar episodes before, if he is an abuser or if any drug and things like this. So a lot of history points should be covered, for these patients, because uh, just to sort out like either the patient have what kind of thing the patient have. And again, like when we go for the physical examination, by the way, we go from the head to toe, uh, checking again if the person is in coma. So you will be doing ABC. What is ABC? A is for airway, B is for breathing, and C is for circulation. I will talk on this like when needed, okay, when I will discuss the emergency scenarios. We check the vitals, we check the temperature, we do the cardiac examination, neurological examination, respiratory examination, abdominal examination. Now, in this case, of course, neurological examination is more important because you have to check the pupils, you have to check the reflexes, you have to do the GCS to evaluate what is the exact GCS of the person or the level of consciousness of the person. So, okay, I'm going to leave this thing because, okay, so the approach is simply how we approach is you can see uh, we see like either the coma associated with normal brain stem function, indicate widespread and bilateral hemispherical decrease or dysfunction, and we check the pupils, check the body temperature, like see you can say like one enlarged unreactive or poor reactive pupil means point towards midbrain lesion, small reactive pupil point towards this thing, and very small reactive pupil, like of course I'm not going to explain these things because there is no point to explain right now, you don't know these things, right? What is spontaneous damage, and your pharmacology is also going on, so you will be studying a lot of side effect of these drugs and hyperthermia and hypothermia, right? As well as see, then we check the respiratory system. If there is slow breathing, it point towards, like, remember opiates causes respiratory depression, okay? If there is deep rapid breathing, so it could be small breathing or respiration, which point towards pneumonia, diabetic, uremic acidosis, or pulmonary edema. So this thing, and then we check the respiratory pattern, we check the blood pressure, we check the involuntary movements, okay? So now like this one is more neurology, by the way. in this slide, of course, like because this slide I made for typically for some neurological topic, right? So, but of course, like I explained you this what is vegetative state and what is locked in syndrome, right? There is something called as akinetic mutism, and as you will just pay attention on this term, like akinetic, like there is no movement, and mutism, like the person is quiet. So the in this one, like they remain immobile and silent when they get stimulate. Okay, when we stimulate, of course, when we stimulate or someone stimulate them. So the problem could be like hydrocephalus or large bilateral lesion in the cingulate gyrus. Okay, so you can see like here they are showing the patterns like someone who have a small episode of loss of consciousness or transient loss, and someone who have a sudden loss of consciousness which is going on, and someone who have a progressive decrease in consciousness, like someone who have a rapid deterioration with regaining a little. So they're talking about like someone who have a small or transient loss of consciousness. So think about syncope, seizure, subarachnoid hemorrhage, and brain concussion. Or think about the traumas. And someone who got the loss of consciousness and they stay like that. So think about brainstem stroke or head trauma. And someone who have the progressive loss of consciousness, think about metabolic derangement, sepsis, intracranial space occupying lesion, or hydrocephalus. And this one is like someone who have like deterioration and rapid deterioration, and then like a little coming back of the thing. So B clouded dementia due to systemic problems could be the cause. And okay, so I talk about the vegetative. I told you what is vegetative state. I told you what is locked in syndrome. I told you like this one is the brainstem is damaged, and there is quadriplegia and lower cranial nerve palsies. But the person they still have a lot like consciousness is maintained. So uh, syncope or blackout, they are most or less same things, right? So these are the difference between the syncope and the seizure, if you can see, okay, how a patient with syncope behave and how the patient with seizure behave. Okay, of course, like in this one, you will find the history of epilepsy or seizure or some provoking factor which is causing this thing, and there is no relationship with posture. But in syncope, as I gave you the example, there is relationship with the posture, and a lot of things they have given in this one. So anyhow, um, if you'll talk about the vertigo, um, now one of the thing which should be mentioned here about vertigo. Vertigo is like it's a symptom, okay, and the persons like when they feel like the objects or the environment around them it is revolving, so we call it as vertigo, and it could be like many causes, like the central causes as well as the peripheral causes. Like it could be due to the diseases of the inner ear especially. Okay, and most of the time whenever there is vertigo, it is associated with nausea, nausea and vomiting, you can say, right? So see here they are talking about uh, vertigo, presyncope, disequilibrium, and lightheadedness. So see, vertigo is illusion of movement, usually rotatory of self or surrounding, and whereas presyncope is sensation of impending loss of consciousness. When you are doing something and you suddenly you feel like you are going to lose your consciousness soon, we call it as presyncope. And disequilibrium, as you know what is equilibrium, so disequilibrium is like when you feel some unsteadiness or imbalance, and lightheadedness is like it's also called as dizziness. It's like when uh, you feel, lightheaded is a feeling. See here, even here it is written like there is no clear definition for that. So sometimes you feel like your head is, there is nothing there. Okay, and if I will describe that, I will describe it like as you are in a air, right? Like your head is in the air, you can say. So this term is now used interchangeably with presyncope. Now see, whenever like any patient comes, so one of the thing which we have to, you can say, sort out in the patients is what the patient really have. Either like, so the person is complaining, see, I am dizzy. So now you have to think about either it's vertigo, on the history, of course, either it's syncope, either it's disequilibrium, and either it is ill-defined or psychiatrical. So the important thing over here is what like uh, of course, like we must know what are the questions we must ask about in a patient who is complaining of dizziness or vertigo. Okay, like because we must know um, like what actually patient means. Okay, and then of course when we know that the patient have dizziness or vertigo, then we can deal with that. Okay, otherwise of course like you cannot deal with that thing. So now uh, vertigo, which is illusion of rotational or linear or tilting movement of self or surrounding. It could be a ear problem or it could be a brainstem problem. Like we classified like either central or peripheral. You can see over here. Whenever it is central, it is brainstem problem. Whenever it is peripheral, it is ear problem. Okay. Syncope could be cardiac, could be vascular. Disequilibrium is most of the time neurological and ill-defined, or like it looks like somewhat some sort of psychiatrical system symptom. So see, there is a true vertigo, or dizziness can also be called as pseudo vertigo. So dizziness can be anything like lightheadedness, giddiness, faintness, or what I was saying, like you feel like you are in air. Whereas true vertigo, as I told you, the definition, it's like when you have a feeling of any movement of self or surrounding, like the things are moving around or you are moving in the environment, right? So these are the causes. Like of course you won't understand these things or these things or these things or these things, of course, like because this one is more like internal medicine, which will be started soon. So again, vertigo is the hallucination of movement of the environment about the patient or of the patient with respect to the environment, and caused by the disorder of the labyrinth or brainstem. So of course the problem can be in the labyrinth or in the ear, or the problem can be in the brainstem, which is like the central vertigo. So there are different conditions like vestibular neuronitis, and this BPPV is basically benign positional, paroxysmal positional vertigo. Meniere's disease is one of them, and rare causes are also written like cholesteatoma, autosclerosis, and things like this. And central vertigo, most of the time, it is due to transient ischemic attack or stroke, or multiple sclerosis are also one of them. And if you cannot find these things, then remember it could be psychogenic or cervical vertigo, or due as a side effect of medications. You can see like this scenario, it will help you a lot. Like Margaret, age 69 years, comes to see you in your GP clinic. She has 3 days history of sudden episodes of dizziness. She describes dizziness as room spinning when sitting up after waking, a sense of falling backward and attempting to lie on the bed, and room spinning when rolling over the bed. She also describes rotatory sensation during the day, predicted by opening a high cupboard or hanging out washing on clothesline. She had been in good general health and had no past history of head injury. She's not taking any medication regularly and had no allergies. Now, see, if you will pay a little attention on this scenario, see, she have these feelings of rotation or the sensation of vertigo whenever her head position is changing. Okay, either see whenever she try to wake up, get up, she try to lay down, uh, like whenever she try to hang the clothes, whenever she try to open a high cupboard, So uh, the things she is having, the symptoms she is having is mostly when she is changing the her head position suddenly. Okay, so see, like Dr. XYZ. Okay, so like, I am Dr. XYZ. How can I help you today? What do you mean by vertigo? Is it vertigo or pseudo vertigo? Like, you have to ask not like this to the patient, rather you have to ask yourself. So see, since when duration or simply the mnemonic odipara, is it continuous or it comes in episodes, and how often you get the feeling? Is it the first time? How it is progressing? What makes it better or worse? And effect of position, of change of position or posture. So see, the odipara is asked in this one, and then see, there will be the questions about nausea, vomiting. Of course, very important. I told you, with whenever it is the ear problem, it comes with nausea and vomiting. And any tinnitus, like tinnitus is the ringing of the sounds in the ears, or deafness. So see, he's checking any condition in the ears. Have you had any flu recently? Like, whenever there's infections, seasonal infections, and whenever the infection affect the ears, they can give these symptoms. Recent colds and any history of head injury. Have you noticed any asymmetry of face? Now he's checking the neurology. Either the person have some stroke, like the central questions. Numbness, tingling in your arm, any trouble with speech, sight, or swallowing, any chest pain, racing of the heart, shortness of breath or palpitations, any change in weight or appetite, to rule out tumors. Do you have any pain in the neck? Are you driving at a movement? Any trouble with it? Then he asked about the drugs like alcohol, marijuana, hypotensive. So, like, ruling out all the causes of vertigo. Okay. So, now I can tell you one more point over here. Simply, before going on to more details, like if you remember the scenario, so what I will be giving you here is the causes of uh, okay, okay. No patient basically come and use the word vertigo, but most, like, when the patients come, by the way, the word they use to describe their symptom, even if they have vertigo, the thing, the word, the word they use is dizziness. They say that, doctor, I feel dizzy. And then you uh, you, by taking history, can cause or can find out the cause of dizziness. So whenever it is dizziness, it could be a vertigo. Okay. um, or it could be you can say non-vertigo causes, right? Or non-vertiginous causes, you can say. Okay. Now, whenever it is true vertigo, so okay, this vertigo, we can mention it as true vertigo. Okay. You took the history and you found that the patient have true vertigo. The symptoms exactly is not the symptom of lightheadedness or other things, rather it's a true vertigo. So it could be, I told you already, peripheral, or you can say the problem can be in the ear, or it could be central. Okay. Or you can say the problem is somewhere in the brain stem. Okay. Whenever it is peripheral, the problem is in the ear. Okay, wait. Okay, the problem is in the ear. Think about few of the causes, like benign proximal positional vertigo It could be labyrinthitis. Okay, you will study this thing in ENT. It could be Meniere's disease. Meniere's disease. Okay, it could be vestibular neuronitis. Okay, it could be cholesteatoma. It could be autoimmune disease of the ear. It could be the drugs damaging ear. It could be like XYZ many things. But whenever it is like due to brainstem, then the causes could be a stroke. And when I say stroke or TIA, so remember, like I'm talking about vestibular-basilar insufficiency, Wallenberg syndrome, cerebellar infarction. Okay, it could be migraine. It could be multiple sclerosis. It could be meningitis. It could be encephalitis. It could be trauma. It could be drugs. It could be toxins. Okay, and it could be tumors. Okay, so TTT, tumor, trauma, toxins. Okay, and remember, like double I, infections, inflammation. So if you can remember, like in this way, how I write these things is like simply I make concepts like this thing. Okay, so whenever you are talking, like thinking about the cause of anything, so remember, like all the causes have two I's, one I is infection, one I is inflammation, and then think about the T's and think about E's like endocrine, and think about M's metabolics and things like this. So this is how I remember the things. And whenever it is non-vertiginous, so it could be organic disease, it could be uh, disease, it could be functional. Functional means like the problem is not some sort of disease, rather some psychiatric type of illness. So non-organic causes, like it could be cardiac conditions like arrhythmias, it could be vasovagal syncope. Okay, it could be anemia, it could be even visual impairment. Okay, it can give this thing. And whenever it is functional, so remember functional, remember psychiatrical illnesses like depression can cause anxiety. Remember, like when you are anxiety, things happens to you. I don't know, like you have experienced these things or not. Like anxiety can give really, depression or panic disorders can give really weird type of symptoms. So all these things can be there, right? Um, okay, neuritis. Okay, or okay. So I talk about the history, then we go for the physical examination. We check the general appearance, BMI, vital signs. So if you know all the causes, these causes, we have to look down in the examination. So in examination, you will be checking the eyes, because even visual problems can give what you can say dizziness. ENT, you will check the ears for any infections, any conditions you found. You will find facial asymmetry to rule out stroke, TIA. You will check for its sclerotic signs because of stroke. You will do cranial nerve examination. You will examine the neck, and there is a Dix-Hallpike maneuver for BPPV. Like again, this is a maneuver you can see over here. With the person, they have like benign paroxysmal positional vertigo. What happens, like there are small stones in the labyrinth. So whenever like the person moves their head, these stones, they move in the fluid, and they causes this problem. So better to see this maneuver on YouTube, by the way. Okay, but like you can read over here, make sure that there is no head or neck injury. From a sitting position, from this position, okay, the patient head is rapidly taken to a head hanging position of 45 degree below the couch and 45 degree to the south, and do 3 times with head straight, rotate to the right, rotate to the left, hold for 30 seconds, and observe the vertigo and nystagmus. So when this one is positive, it means that the person have BPPV. Okay, this is called as Dix-Hallpike maneuver. There is something called as Apple's maneuver that is used for to treat that. So management, okay. Now they are talking about this woman, okay. But I don't think so. You need that right now, okay. So like of course like he diagnosed her with this condition BPPV, and then he will talk about the treatment with the patient, like do Apple maneuver. This is the sort of exercise you will look on, take a look on YouTube, and then you will understand. And then again, one more scenario, guys. Like James, 53 years of age, went to the GP. He have dizziness and vomiting. Dizziness and vomiting happened this morning and lasted for 20 minutes. There is no past history of such episodes in the past, even with his previous migraine attacks. Now he had the history of hypertension, hypercholesterolemia, impaired GTT or glucose tolerance test, and migraine. Heavy smoker for 30 years, runs his own business and is always busy. He lives himself in an independent accommodation as well otherwise. So again, like they will talk about the history, same lines, physical examination, same physical examination, even do this maneuver to rule out BPPV. And now this patient is a case of vestibular neuritis. Okay, so this is like about what you can say vertigo. And whenever like we found any patients with vertigo, I told you the history points. I told you how to do examination, okay, of that patient, okay, just to reach out the thing. So many questions can be asked, okay. And one thing, whenever someone lose consciousness, guys, always ask what happened before, what happened during, what happened after. It is going to give you a lot of information or insight about the condition. So, for example, if the patient will come with, uh, for example, the patient is saying that due to doctor, I went blackout. So now we don't know, like either it was just a blackout or a vertigo or what. So ask about, like, does he lose awareness? Does he injure himself? If he lose consciousness, then ask the people who are observing him. Does his body did any abnormal movements? Does he lose urine or feces? Does he bite his tongue? Okay, so now divide the episode in three parts. What happened before? Ask him, like, did he was having any warning signs, any lightheadedness, any change in he see any flashes of light or things like this. Then ask what happened during the attack from the observers who were observing him. What happened after the attack, like when he regained his consciousness? Either he was having pain in the body, either he was sleepy, he was confused, and all those things. Okay, so divide the episodes in these three sections, and it will help you a lot in in getting the final diagnosis. Okay, so uh, this is like about vertigo as well as like the loss of consciousness. Okay, so okay, so thank you so much, guys, for listening this lecture, and of course, like the next lecture will be okay. So thank you so much, guys.